Bismillah ar-Rahman ar-Rahim. First of all, I'm thankful to Pfizer Pakistan who gave me the opportunity to talk on this topic. And I must appreciate the ethical and legal practices by Pfizer Pakistan. And as this disclaimer is in the view, I must say I have not been to direct or indirect interest in any form in this presentation. This wholly solely is I have prepared this and these are my views and I'm responsible for its contents. In today's world, today's scenario in our part of the world, this saying of William Arthur is very much relevant, where the people are taking self-medication a lot. Well, the topic is uncomplicated upper respiratory tract infection and its management. But let me and give me the liberty of before the actual topic, I want to talk on two aspects of infections. First of all, I would hint toward the disease burden of the upper respiratory tract infection globally and locally. And secondly, I would briefly hint on the inappropriate or misuse of antibiotics and its sequelae. So this is the WHO report that 1.5 million deaths annually at the upper respiratory tract infection. So, and this upper respiratory infection is the second commonest cause of death in children under the age of 5 after the neonatal causes. This is a data which belongs to our province of Khyber Pakhtunkhwa. And this disease surveillance was done by WHO. And the commonest diseases was found in IDP camps, internally displaced camps. As you all know, our province is frontline province and war-torn province. So in IDP camps, this was the commonest disease, upper respiratory infection. And upper respiratory infection has one of the highest figure on disability adjusted life years, which is a measure of the wastage of years in disability or due to early death. They are combined together and get so that is the highest in amongst the diseases in case of upper respiratory infection. Now, the second point which I want to highlight before the actual topic is the misuse or inappropriate use of antibiotics. So this again is a report by WHO that resistant microorganisms developing every day, and over the last 30 years, no major new antibiotic has come. And this high antibiotic resistance, it has got a negative outcome on the health expenditure and the patient outcome. Now, as a result of this, I want to put these 3 points into view. Before antibiotic era, it was in 1942, a 33-year-old woman was dying of streptococcal infection in USA. And then they were able to get small amounts of a substance called penicillin, which was newly discovered, and they gave the lady, and the lady lived up to the age of 90. Exactly 66 years later, in the same country, a 7-year-old man was in San Francisco who was dying of endocarditis. All the sophisticated antibiotics, they were available, but they died of infection. He died still bacteremia. So we have completed our full circle, and we have arrived at a point, frightening point A0 in the pre-antibiotic era. So there is an epidemic increase in antibiotic resistance, and the use of antibiotics, particularly in the treatment of upper respiratory infection, is the area of concern. It should be proper antibiotic with proper duration and proper dose. And we have to adopt certain educational strategies to overcome this problem. Now, having said this, I'm coming to the actual topic, which is the uncomplicated upper respiratory infection. This term denotes the inflammation of the mucosa of nose, pharyngeal sinuses, pharynx, larynx, and trachea. And this non-specific upper respiratory tract infection is in the common language called common cold, zukam, pashto, bekefe, yakni. These are various terms used for this disease, which is a non-specific infection. And due to this, the rhinosinusitis, the sinuses are affected, the pharynx is affected, bronchitis occurs, and acute otitis media. These are the areas shown which comes under the domain of upper respiratory tract. Now, let's discuss the common cold or non-specific upper respiratory tract infection, which is most commonly due to viruses and the viruses involved are rhinoviruses, parainfluenza, adenovirus, despite sensation influenza. Bacterial rhinosinusitis complicates this viral infection only in 2% of cases. Though viral infection is also inflammation, there is pain and fever, but the degree is very low as compared to bacteria, where the degree of symptoms is very high and the duration doesn't go beyond average 7-11 days. Viral infection, upper respiratory, is specific to weather. In our part of the world, it's common in winters and fall. There are a few facts, pathological facts about the viral non-specific upper respiratory infection, which I want to put forward to you so that we may understand the proper medication to treat it. Purulent nasal secretion alone do not detect bacterial sinusitis. So if there is apparently purulent secretion, we should not take it as bacterial infection because it's stuffing of the mucosa that is coming due to infection, due to infecting viruses. So yellow secretion, green or yellow secretion, they do not necessarily points towards the purulent secretion. Inappropriate use of antibiotics in cargo. This statement, these three causes has been given by the BMJ, British Medical Journal. They say that unrealistic patient expectations for antibiotics. And there is pressure, even in the developed world, pressure by the patients on the physician to prescribe antibiotics. And third point is insufficient time to educate patients about the ineffectiveness of antibiotics. So if they can complain of insufficient time, what will be the situation in our part of the world where we see hundreds of patients in outpatient department? So this is a sort of global phenomenon, and in some respect, it's more severe in our country. So the reasons why prescribed in Pakistan and in other underdeveloped countries is lack of proper implementation of drug regulations, sex education, and quackery, which is rampant in our part of the world. Acute infection that is typically viral in origin involving the upper respiratory infection, and the viral symptoms are low in intensity. Pleural secretion from the nose, or throat, they do not detect necessarily bacterial infection. When they are not accompanied by other parameters of bacterial infection that should not be taken, it should not be taken as bacterial. Antibiotic use of therapy for non-specific infection of it does not enhance the illness resolution. The antibiotic does not enhance the illness resolution. It is not recommended as long as the diagnosis is viral. And if we exclude bacterial superimposition, then this treatment is sufficient for viral infection, which is adequate to intake, rest, notified ear, and over-the-counter analgesic antipyretic histamines. Now we take up one by one in the different region of the respective tract. So acute sinusitis in adults, inflammation are already defined up to the mucosa of the areas. And this is the most common diagnosis in ambulatory upper respiratory infection. And many times, even physician advise X-ray. It should not be advised in acute stage, in the first stage. Now, clinically, how can we identify that this disease is bacterial or not? So there are three parameters. Any one of them is present, we can clinically diagnose that it is due to superimposed by bacteria or primarily by bacteria. If the symptoms are persistent from the very start and are prolonged for more than 10 or more than 10 days, or the symptoms are severe right from the start, 102 degrees Fahrenheit fever, pulmonary discharge, and it is continuing for 2 to 4 days. And the third sign, which is also called double thickening sign, there is a common cold. Symptoms are there, but after a few days, the symptoms become severe. So this is again a sign of bacterial infection. So these are any one of these present in a patient, we can clinically diagnose it as a bacteria. And once we diagnose a case to be acute bacterial sinusitis, immediately empirical treatment should be started without waiting for the culture and sensitivity. And the common pathogens are Streptococcus pneumoniae, Haemophilus influenza, Marburg picarelis, and the drug of choice for these bacteria is amoxicillin chlorinic acid. And in certain situations, we may have to give double dose of this antibiotic, for example, in endemic areas where the invasive penicillin, non-specific, non-susceptible Streptococcus pneumoniae is prevalent. And in severe infection, where there is sign of systemic toxicity, high-grade fever, attendance at daycare center, very old people and small kids, recent hospitalization, recent use of antibiotic, etc., are an immunocompromised patient. Doxycycline may be used as an alternative to amoxicillin chlorinic acid for initial empirical antimicrobial therapy for acute bacterial sinusitis in adults because it remains highly active against respiratory pathogens and it has got good pharmacokinetics and pharmacodynamics. And it is useful in adults, not for children. Other antibiotics which can be used as an alternative are all the beta-lactam antibiotics or a combination therapy of third generation cephalosporin with clindamycin. It is used as a second line therapy for children with non-type 1 penicillin allergy. Which antibiotic antimicrobial regimen are recommended for the empiric treatment of acute bacterial sinusitis in adults and children? So either doxycycline, not in children, or respiratory fluoroquinolone. In adults, these two. In children, levofloxacin is recommended for children with a history of type 1 hypersensitivity to penicillin, or a combination therapy with clindamycin of any third generation cephalosporin. The duration of therapy should be in adults it is a week and in children it's almost 2 weeks. Adjuvant to antibiotics, you can give intranasal saline irrigations, steroids, and topical or oral decongestant retinoid in acute sinusitis. If there is treatment failure despite giving antibiotics and other adjuvants, and after you wait up to 32 hours, there is no relief, so one should think of alternatives. First, should think of a resistant bacteria we should think of other possibility, non-infective possibilities like structural or possibilities, non-infective. When there is treatment failure is suspected, we should take a fresh swab, which should either be from the sinus directly by aspiration or endoscopically from the middle meatus from the area of middle where the sinuses are drained, osteometric complex. At times, patients of acute bacterial sinusitis may have to be admitted to hospital because of serious illness, immunocompromised. If clinical deterioration are there are recurrent bouts of acute sinusitis with clearing in between. So such patients should be admitted into hospital. So this was all about the acute rhinosinusitis. Now, acute pharyngitis. A definition already given, we have discussed it, and the nasopharynx, uvula, soft palate, these are the areas which are involved, and this is the list of viruses, and the last one is the group A beta hemolytic Staphylococcus. Group A beta hemolytic Staphylococcus is the bacteria responsible for acute pharyngitis if it is bacteria. Most pharyngitis are viral in origin, and the presence of conjunctivitis, cough, rhinorrhea, and excessive fevers, it hints towards viral cause. How to treat group A Staphylococcus beta hemolyticus? Accurate diagnosis of staphylococcal pharyngitis followed by appropriate antimicrobial therapy is important for the prevention of its complication, for the prevention of suppurative complications like peritonitis, improving clinical signs, symptoms, and the rapid decrease in the contagiousness so that it should not spread to other people, and the minimization of the potential adverse effects of inappropriate antimicrobial therapy means to reduce resistance. When to treat with an antibiotic? When there are symptoms of sore throat, fever, and headache, and signs or we check the temperature. If it is a high grade, there is tonsilopharyngeal erythema, parietal fatigue, tenderness of inferior group of lymph nodes in the neck, and excess of cough. Whenever there is cough, it hints towards the viral and disease portion chart. We can confirm the diagnosis by throat culture or rapid antigen testing. If rapid antigen testing comes negative, it should be done with culture again. But if it is positive, it is sensitive, very sensitive, and treated accordingly. So, how can we diagnose clinically? And throat swab and culture. The treatment for patients with group A beta hemolytic Staphylococcus pharyngitis is appropriate. This word is extremely important. Appropriate, again, I say it in terms of appropriate antibiotic, the nature of antibiotic, the duration, and the dose. And it's based on the narrow spectrum activity, the amoxicillin. Amoxicillin is the first choice. If there is allergy to penicillin, then cephalosporin, clindamycin, and clarithromycin, and azithromycin. So the clindamycin, clarithromycin for 10 days, and azithromycin for 5 days. Next is acute bronchitis. Acute, again, slight infection with normal chest radiograph. This is the criteria of acute bronchitis diagnosis, which has been specified by cough with or without sputum, and if it lasts for more than 3 weeks. Greater than 90% of cases of acute cough illnesses are non-bacterial. Viral illnesses include influenza, parainfluenza, respiratory syncytial virus, and adenovirus. Bacterial agents include Bordetella pertussis, Mycoplasma pneumoniae, and Chlamydia pneumoniae. Acute bronchitis, if the diagnosis is bacterial. So in viral, antibiotic is not indicated. And you should rule out any serious illness in adults, particularly pneumonia. Pneumonia is not common in non-elderly adults. In patients with cough lasting for 3 weeks or longer, chest radiograph may be warranted in the absence of other cases. Treatment is reserved for patients with acute bacterial, exacerbation of chronic bronchitis, and COPD patients. Otitis media, this is the last group of this infection. This is defined as inflammation of the middle ear, and it can be classified as acute and chronic suppurative media or suppurative or non-suppurative. So there are different schemes of classification of otitis media. We are more concerned here with acute otitis media, which occurs due to upper respiratory infection, which is a short-term ear infection, often comes on suddenly. The onset is sudden. The chronic otitis media, on the contrary, is ear infection which keep coming back. One infection lasts for more than 3 months. Then it is called chronic. It has got less severe symptoms, and at times symptoms the infection might have been unnoticed and untreated for a long time. So the complications with this are more. Viral upper respiratory tract infection has shown to precede most cases of acute otitis media. And the pathology is the second tube is blocked. It is inflamed and it is blocked. It becomes dysfunction. Negative pressure develops in the middle ear, and parametric secretions containing infection virus and pathogenic bacteria, which colonize in the and then enter because of the negative pressure, they enter into the middle ear from the nasopharynx. And bacteria advances cause inflammation in the middle ear, resulting in accumulation of fluid, which may be suppurative or non-suppurative. The 3 criteria for acute otitis media include acute onset of symptoms, which includes fever, the child is irritable, and there is earache. And there are signs of inflammation of the tympanic membrane. When you see the tympanic membrane may be wet, congested, or in less severe cases, the congestion will be along the periphery, along the rim and the handle of Malleus. Other parts may be speared. That is a bit less severe in case less severe case. And there is a fluid and mild bulge of the tympanic membrane. The features of uncomplicated acute otitis media in children between the age of 6 months to 12 years, there is moderate to severe tympanic membrane bulging or new onset atoria not caused by acute otitis external. There is mild bulging of the tympanic membrane with ear pain, solicited panitas, or infants tympanic membrane erythema is already told. And there are a non-verbal child, the children who have not yet got the speech, they get hold of the ear again and again, they are tugging the ear and they are rubbing. It suggests that there is pain in the ear. And the acute otitis media should not be diagnosed when the laparoscopy and or tympanometry do not show medical feeling. There is accumulation of fluid. The fluid, of course, may be non-infectious, just exudation, but it may be pus as well. And the treatment should include pain evaluation and treated accordingly. The treatment of should be prescribed for bilateral or unilateral otitis media, as the case may be. Those children between the 6 months with severe signs and symptoms, moderate or severe otalgia for more than 48 or more than 48 hours, there is high-grade fever. So amoxicillin is the antibiotic of choice for such children. Should not be given to a child who has received. Amoxicillin should not be given to a child who has received it in the last 30 days, or there is concurrent pleural conjunctivitis, or is allergic to penicillin. In these cases, an antibiotic with additional beta-lactam activity should be given. Re-evaluate the child whose symptoms have worsened or not responded to the initial antibiotic treatment within 48 to 72 hours. This point is extremely important because if till 72 hours there is no improvement in the symptoms, despite giving antibiotics, so antibiotic might have to be changed. The current acute media in those children who have got grommets are ventilating tubes and they are not prophylactic, but the not prophylactic antibiotic may be indicated to reduce the frequency of acute media episodes. So, I have reached to the conclusion that this is a sort of home take message. Upper respiratory infection is one of the major public health problems, and globally it is responsible for more than 1.5 million deaths annually. Viral antigens account for most of these cases. However, their symptomatology, their severity is mild and self-limited. Infants and young children are prone to developing infection, which results in serious complications. So, the rate of complication may be more in case of children. This infection is responsible for the reason for 60% of all antibiotic prescribing in general practice. Antibiotic may be beneficial only for a subgroup of patients who present with respiratory infection in primary care settings. And that subgroup, as we discussed earlier, is of the ones who are bacterial from the very start, or those who have become complicated with bacterial-separated infection. Increasing antibiotic resistance resulting in negative health outcomes and increased socioeconomic burden. This point I want to emphasize again and again. This increasing antibiotic resistance is posing a lethal threat to the whole of the humanity. To reduce this, all hospitals and general practitioners should adopt to practice antibiotic stewardship. Antibiotics in one part of the country may need to be given differently. They should be based on our history of infection in our hospitals and our settings. So with this conclusion, I come to the end of this presentation. And now if there are any questions, you are most welcome.
Thank you very much, Doctor, for a very nice presentation on very important topic.
Well, I expect that there should be some discussion from the audience on the topic of the inappropriate use of antibiotics or the choice of antibiotics used in infections in the upper respiratory tract. The disease burden that is, I think, that is also given, it is clearly given in WHO is time and again emphasizing it and pointing towards the appropriate use of antibiotics to improve the outcome of the treatment on one hand and to reduce antibiotic resistance. Because if we give an antibiotic which is empirically not suitable for a bacteria, the bacteria which is responsible for an infection, so that will lead to resistance. If we gave it for an inappropriate dose, or if we gave it in the duration of antibiotic treatment is not appropriate. So all these factors may lead to resistance development. The more we practice it and the more self-medication, the more quickly, every day there are increasing number of resistance bugs. So I hope if there is a question, some of the audience, they may comment on it as well.